So week 8, I'm just so impressed with week 8 already. It's almost done. We're almost doing HESIs. We're almost on exam 3. Exam 3 is week 10. I will be doing some live reviews next week. I'm going to be doing the live review on Tuesday, 5:30, and I will be sending you when the other professors are going to do it. Again, it will be on YouTube on my channel. Do you know there were 685 views of exam 2, my review? I was like,
go ahead. Praise the roof.
You know, I'm going to be a YouTube star. I put myself there in public for you. So you, and not only you, all of pediatrics can be taken care of, because I believe that nursing is one, but you need to know how to get to everyone. And I don't know, it was easy to get on, so I figured it out. So I said it works. So anyway, I was impressed with that. So we'll be doing those reviews. I'll be putting mine up, and of course you'll be getting the other reviews too. If you look at your calendar, I do put the reviews on the calendar with the Zoom links. So it's really easy for you all if you want another person to hit one of those other links. It's just right on the calendar. So I will be sending out the PowerPoint probably either tomorrow or Saturday. I have just done all of the make it look pretty stuff. Now I am making sure all the information I want in there is there. Because, you know, we have one that we build upon. So making sure it's written correctly, making sure there's pictures that actually describe things, because I believe pictures tell a lot. I think pictures sometimes when you're describing something can make you understand. So I've been doing that for the last 2 days to get that up. So you'll get as soon as I can. So this week is a busy week for you. You've got some case studies due. Quiz 5 is also this week. And just to let you know, when you go to Kaplan next week to do the math, it is not what it says on the syllabus. It's a different name. They changed it. We, changed it good on the syllabus, and before we could get, back and do it again, they changed the name again. So it's called Advanced Math Peds A. It's sort of similar to the name. So if you see something that's similar, use that one. And please, please remediate. If you don't remediate, you only get half of your earned grade. So even 100 must be remediated. If you don't, it is a 50. So just to be very aware, I will let you know if you don't remediate. I will send you a message. I will be doing the remediation and looking at all of that when I get all of the Kaplan in. So when A, B, and C peds are done, I will go through Kap and look at it, let you know you didn't remediate this. Do you want to get your full grade? And then you could let me know when you've done that. I mean, I try to work with you because I know sometimes you just forget, and I understand that. The dosage calc is due, and the pediatric assessment project. As soon as they are coming in, I am reviewing them. If there is something that I feel that you could make better for a better grade, I will tell you. If it's plagiarized too much, I will let you know, because if you don't change, I have to report it to the campus. And I don't want to do that, because I think sometimes it's very innocent. It's not something that you went and, wanted to do, but it's just whatever. So I make sure that you have all the information you need and you can make the changes as needed. So if they're coming in today, I am doing them by tomorrow. So you're getting them out quick and you can make those changes by Sunday. So we're going to be going over GI/GU. Were you all able to look at the handout that I sent? I'm going to put it in the chat right now, so you also have it. It's another one of those matching things. Again, I go through the book and I go through all of the diagnoses, things that you need to know. And I just do a quick, brief description on what it is. So it's going to help you understand things a lot better. It is a great studying tool also. So I made that a couple of years ago from on ground, and I made it as a quiz. And I've realized it was one of those things that I realized as a handout is better. As you're listening to lecture, you can actually, be doing it. I will send you the answer sheet, but I was going to let you try to do it by yourself first, okay? So let's go ahead. Let's get started with our PowerPoint. And then we're going to do a Kahoots. I think Kahoots is like 40 some odd slides, 44, I think. Now, GI and GU, you're going to be surprised, especially GI, how many pediatric diagnoses are there, things you've never heard of before. So I'm going to try to make them understandable for you. Well, if we think of the most popular of all genital urinary, problems with the kidney, bladder, it's a urinary tract infection, really common. And why? Well, especially when children are being potty trained, we're trying to wipe front to back. And of course, little children don't do that, or they're holding it longer because they're trying to get to the toilet, or they're just afraid to go in, and do that. Also, constipation can cause these things. And then, the fashion today is those little tight little, pants, those tights, with a cute little shirt and the hair up, little girls, really cute. But these tight polyester type materials can hold heat and really can create urinary tract infections. So we recommend cotton underwear, and to let them breathe, and no bubble baths, because all of that beautiful stuff and that smell, and it's so much fun, it does lead to urinary tract infections. The other one is uncircumcised boys, young ones, especially if the parents are not retracting the foreskin, once a day and cleaning out that cheese-like substance, the schmegma, out of there. It's like a petri dish. And if you don't clean it out, it's going to create infection. So getting that cleaned is very important. So when do we know a kid has a urinary tract infection? Well, I think if they're sitting there holding themselves in that area and they're bouncing back and forth and, no, I don't have to pee, or keep running, well, that's a big clue. If you're seeing children who are already potty trained being incontinent, another clue. And then, of course, if you smell something foul, we know that's going to be, and of course, the frequency and urgency. In girls, sometimes you'll see some redness between the labia, and that's also another clue about it. So how do we prevent? Well, I've sort of mentioned it, and it's number one, making sure that we are trying to catch it before it becomes more than just a urinary tract infection. So if a child is exhibiting any symptoms, to get it checked out. Also, normal showers, cleaning, especially after exercise, no bubble baths, clean front to back. And with the adolescent age group, if there are girls having frequent urinary tract infections, ask them if they're sexually active, because if they are, they need to urinate soon after intercourse as possible, and that has shown to decrease urinary tract infections. So we bring the child in, and we need to diagnose, what's going on, and we need to treat these children. So we're going to do a urine culture sensitivity. Remember, the young infants, we're going to do a catheterized specimen. And the reason is a bag urine skin contaminant. Plus, there's also some substance in between the labia, which could be a bacteria. So we're treating that and not the urine. So if we do a urine catheterized specimen, we're getting a good specimen, and then this specimen will tell us which antibiotic should be used. So if we start them on something that could be something else, we'll change them. And this will stop a progression of urinary tract infection going on, because you would finish, if you didn't do this urine cath and you didn't have the CNS that we need. We would be treating something that, you know, it's not going to work in the bacteria. Then they're going to have symptoms again. You go back for different antibiotics. So one time we can take care of it. In the premature, we do suprapubic aspirations because there's nothing small enough. We just clean the skin above the symphysis pubis. We stick in a needle, a 3 cc syringe, pull out maybe a half a cc, and we use that for a culture on these children. It works really well. Most of these kids are already sedated, so it's not that painful. We can do a kidney tap for some children who have, you know, chronic pyelonephritis, which infection in those kidneys are really bad. We can also do a bladder washout. What's inside that bladder? What sort of sediment? What is it? An ultrasound can show structural issues. Is it some sort of valve that's, you know, or the ureter doesn't go all the way through, it's kinked, or, you know, some sort of fibrous, you know, band is around it and it blocks it. It can happen. Voiding cystourethropographies are done for those children, mostly into the toddlers with frequent urinary tract infections, again, to rule out some structural problems. IVPs, the intravenous pyelography, most of them are done for kidney stones, to look for that in the older child. So renal biopsy, what is your responsibility? Well, this child is going to be premedicated somehow, whether it's sedation, usually just midazolam to get them quiet. But they should be NPO because we don't want them to vomit. And we will take vital signs, explain to the child what position we'll turn them into. You know, some physicians like them sitting up, some like them on the side, whatever the physician wants. Now, once we're done, it sort of sounds like a cardiac cath post-op procedure. We're going to put pressure on that area where that biopsy of the kidney was done, because we could leak urine. We could leak urine out onto the bed or leak inside the peritoneum. So we want a nice, good, firm pressure there. These children are in bed 24 hours. And they can eat, drink. There's no constraints on lifting legs or sitting up. That's okay. We also, because of this probability of peritonitis due to a leaking urine, watch for the abdominal pain. If it hurts, something's going on, because urine does burn. It's going to hurt. So you see that tenderness, pain, it'll be a sign. And of course, intake and output's really important. What's the child urinating? Are they urinating enough? And if they're not, where is that urine going? I mentioned obstructive uropathy. As I said, it could be anywhere. It could be one side, both sides. It could be the complete thing, little tiny little portions. It's all different. And once we determine that there is a stricture, so if you can't get urine from the kidney down into the bladder, and that ureter is blocked, where is that urine going? It's going back in the kidney. And what is it doing? It's destroying it. It's killing it slowly. So if we go in, we figure out there's a little kink there, we need to fix it, we can do surgical correction, open it up, and we can save the kidney and have bilateral ureters draining into, you know, the bladder, which is what we want. That's what we want the most. This picture's in your book. I put it here just to show you different things that it could look like. And now we're going to talk about nephrotic syndrome. First of all, nephrotic syndrome is nothing to do with kidney failure. It's not chronic kidney failure. It is not acute kidney failure. It's the body, the kidney's inability to save protein. Doesn't know that need to save protein, so you get rid of it. So you're going to see proteinuria, which looks like that glass of beer there. It's foamy urine. That should be a sign. And because it doesn't like protein, and what does the kidney do? It filters blood, right? All the protein in the blood is going to be really decreased. So we've got to be worried about giving medications now, because we don't have, you know, all of that protein there. And what's going to happen is going to have higher blood levels, drug levels. Now, because there's no albumin protein in the intravascular, what happens is it starts to seep into the interstitial tissue. And this is when we start seeing edema. You'll see it around the eyes. You will see edema everywhere. It's not just legs, it's not lungs, but it's all the skin everywhere that you're going to see it. And this is because of the loss of protein. Another picture from your book, it just shows you all of those things that can happen with it. I've basically described it to you. So you, as a nurse, what do we need to teach? What do we need to know about it? Well, these children are immunosuppressed. These children are at risk for infection. So good hand washing, basic. Because they're swelling and they could swell in their mouth and their gums, it hurts. So they're losing their appetite. They're swelling, they have edema. When you think of that with an adult, you think salt restriction and fluid restriction. Same thing with children here. If you're already swollen, we're going to do everything manageable to keep the swelling down. So salt, fluid restrictions. And let the family know that this is lifelong, that this is something that's not going away. And, you know, I had 6 brothers. They teased me about everything. You know, if we can teach the siblings not to tease their sister or their brother about not drinking another soda or not using salt, it can help. Those little things do help. So again, we need to reduce the amount of urinary protein that's excreted. These children get steroids, corticosteroids, anti-inflammatory is what's used on them. We need to reduce that fluid retention in the tissues, okay? And again, infection. We don't want infection. So as a nurse, we're talking about fluid balance, edema here. We're monitoring, you know, their salt and their fluids. So as a nurse, how are we going to monitor fluid balance? Strict INO daily weights, really important. Priorities, strict INO and daily weights. We'll tell you, are they gaining or losing fluid? Now, I've told you there's 2 different types of diseases that are affected by a strep infection that wasn't treated or undertreated. And then this is one is called acute glomerulonephritis. Usually happens 2 to 3 weeks after the strep infection. And what happens is these children stop urinating. And then, of course, if they're not urinating, these children are going to start to swell. And when you don't urinate, you're swelling, your blood pressure goes up. You will see, again, proteinuria on these children, and you'll see hematuria on these children. So these children who have glomerulonephritis will be treated with antibiotics to clear the infection, and most of them completely recover with no problems. Although, if it's not caught quick enough, and in some cases, it could be chronic, which means coming off, coming on, you know, that they're going to have to be treated periodically for this. So manage the edema, daily weights. Number 1, INO. And because it's kidney, we always do abdominal girth circumferences to measure that, because fluid could go there with the swelling. Their nutrition, their hypertension, they're not urinating. Again, edema, same things, low sodium fluid restriction, and they're also susceptible to infections. Very similar to nephrotic syndrome, but they're a different concept, but the same sort of management. Hemolytic uremic syndrome is an uncommon disease, but it is, you'll see blood in the urine. And what happens is you go into thrombocytopenia, anemia, and go into renal failure. And these ones here, they recover completely. But these children will show signs of thrombocytopenia, which, remember, any kid who has, or an adult who has low platelets, thrombocytopenia, P platelets, you always watch them for signs of bleeding. We've mentioned Wilms tumor before, but it's a nephroblastoma. So it's a kidney tumor. Boys, age 3 to 5, African-American. We do radiation, we do chemo and surgery. And we know the big thing for the nurses, do not touch that belly at all, because if you touch it, they're fragile and it could put metastases into the peritoneum. Children do have chronic renal failure, and they also can get acute renal failure due to different things. You know, that urinary tract obstruction that's killing that kidney, that ureter that's blocked can cause acute renal failure. So once we fix it, we could get it going. And chronic renal failure is usually some sort of congenital anomaly, and it could be due, you know, hereditary, something, you know, with the family. So in acute renal failure, all of a sudden you start to see that they're stop urinating. And then of course, you're gonna see all those fluid balance with it, electrolyte issues, potassium up, etc. Now, acute renal failure, one of the most common causes of acute renal failure is dehydration. That's why I've seen children vomit 2 times and they are volume depleted and required multiple boluses of fluid. So dehydration, we need to be really concerned, you know, about children because it can cause renal failure. Chronic renal failure, they said, is more than 50% of the kidney is destroyed. And then it progressively gets worse and worse. They call that uremia. Now, causes of chronic renal failure. Well, it could be congenital problems, urinary tract malformations. It could be something to do with urinary tract infections. I was working as a clinical supervisor for another nursing school, and I was at my hospital, but I was up on the GU floor. I never worked a GU floor. I think I was floated there once in my many years there. And I noticed that they had a kidney dialysis room. I'm like, we do that much children dialysis? And whenever I walked in there, there was a lot of children having dialysis. So I said, why? Why do they have to go through dialysis? And in the culture in Miami, what they told me is a lot of their patients of one culture tend to intermarry. They were marrying first cousins, and that caused these abnormalities to occur. That's one of the things that was here. Now, again, it could be that chronic infection, could be glomerulonephritis, untreated strep throat, or lupus. Lupus kills any organ, so kidneys can be also attacked also. And then of course, anaphylactic purpura. You have an anaphylactic response, it can go to the kidneys. So how do we manage chronic renal failure? Well, we want that kidney to work the best it can for as long as it possibly can. That has to do with fluid balance, electrolytes. These children or adults with chronic renal failure, all of them tend to have very low hemoglobin hematocrits. Their cells are not formed well, they die quick. So they are in need of transfusions, but we are starting now, instead of having those transfusions, to give them erythropoietin, which is a drug that we give that will stimulate the body to make its own red blood cells. So it's going to decrease the need for blood transfusions. And in any illness in children, try to let them be as normal as they can. A child on dialysis will have to go into somewhere 3, 4, 5 days a week, depending. So, you know, in their time, let them still be a child. They're still children. Now, one of the type of dialysis that we use for our younger children is peritoneal dialysis. And that tube in that child's abdomen is a peritoneal dialysis catheter. Now, young children can't have hemodialysis. There's that flow in the arterial and venous lines. That's just way too much pressure, and it will take the brain vessels and explode them and cause hemorrhages. So you can't do hemodialysis. So we do peritoneal dialysis, and it works really well. These children, we use their abdominal cavity. We insert a diastolate a warm diastolate, let it sit in there for a while, and then we let it drain. Now, there's certain cycles they go through. So there's a machine that you set, and the nephrologist will give us whatever fluid's going to go in, the diastolate, and we will set it to go 20 minutes, let the fluid, whatever amount, go in. Let's say it's 200 mLs to insert. Once it's inserted, they let it sit. It's called a still. Maybe 20 minutes, 30 minutes. And then it'll drain, and then I'll let it drain into Foley catheter bag. Usually that's one cycle. Usually each infant will do 8 to 10 cycles at night while they're sleeping. This is not during the day, this is at nighttime. Now, the thing and the problem with peritoneal dialysis is we do send them home with parents. I met one parent who was doing it for 2 years. This child never had an infection, and this child's dressing looked as good as the way I put one on. She was amazing. But the concern is this is a sterile procedure. These children can get infections and peritonitis. The biggest problem that we're worried about is that peritonitis. So if we see a red abdomen, tender, or if we see the color of the drainage changing or some, sediment, we need to let that doctor know immediately, and we need to start antibiotics. The best thing about this is they can stay home, but we have to protect that abdomen. So what best describes acute glomerulonephritis?
B?
It is. It's a streptococcal infection. Yes, thank you. So GI, there's a lot of GI stuff going on, okay? So try to make sense or tails of it. Now, the GI tract does all the absorption, gets all of our vitamins. We eat, GI tract, mouth to anus, we eat, goes in, and we use those nutrients, and it makes us strong and lets children grow. There are reasons why children don't get all of the nutrition they need. I mean, we've learned about cystic fibrosis, sickle cell. I mean, you've heard about, nutritional issues in HIV and the adults. They're the same as children, same thing. Food allergies. Children have a lot of food allergies, and we know that's why we will just increase their foods. At 6 months, we'll do one at a time, wait 3 to 5 days in between. It could be a rash as broad as this one, or it could be very minor rashes, or you might see an intolerance by maybe diarrhea, or constipation, or abdominal pain, or vomiting. It might be that. The biggest of all of the intolerance is those lactose intolerance. And those are usually your bottle-fed babies, and we'll know that as a newborn, they tend to be vomiting a lot. They're switching the formula quite a bit. So GI dysfunction does, because they're not getting all their nutrients, because they're spitting up usually, losing formula, losing calories, they can have growth failure. It could be nausea, vomiting, diarrhea, constipation, anywhere, GI tract, right? It could be abdominal pain, could be bleeding, jaundice. I mean, jaundice means something's going on with the liver, not secreting bile. We're not digesting fat. Something's going on. There is a syndrome called Pierre-Robin, who has children who are, a lot of them are dysphagia. They cannot swallow and chew that well, and they choke on their food. If you can't eat, you can't drink, you're not getting nutrition, right? And then we don't think about it, but fever burns a lot of fluid. If we don't have enough fluid, again, it can cause renal failure. That's one thing, but also not enough fluid, you cannot get the food down the tract. Could end up with even constipation. So dehydration, we've mentioned it here and there, but dehydration means too much is going out and not enough's going in. This picture, I love this picture. This infant is pale. The nose is pale. The lips you can barely see, but the ears should be pink. And you see that fontanelle, it's sunk in. And it really looks like this baby's just sitting there. Infants are the easiest of all to tell if they're dehydrated. If we have a front view, probably the eyes are even sunk in. I mean, that's how dehydrated these and how much they look, when they get dehydrated. It can happen on 1 or 2 vomits. It doesn't have to be vomiting for a day or two. I've seen 2 big vomits cause dehydration, requiring lots of fluid. So you're going to evaluate these children. Vomiting, diarrhea are easy. Good diabetes and ketoacidosis, burns is going to burn fluids. But in dehydration, what are you looking for? Well, I'm going to first look. An infant, fontanelle, I can see it, the color, and then go from there. Heart rate elevated, blood pressure down, capillary refill prolonged, and decreased urinary output. These are things that you're going to see. Measuring intake and output, we can measure urine, vomit. We can measure sweating if we need to. I really have never had to in my career. It would have to be profuse sweating for it to be. Put a chucks under them, see what the chuck weighs before and after, and get some guesstimation. Vital signs, telltale. You can see heart rates going up, coming down. I mean, I have seen vital signs, a heart rate. So we've noticed the child is decreasing urinary output, showing signs of dehydration, and they're on a monitor. And I'm going to push in some fluids. I can watch that heart rate come down as I push the fluids in. That's how significant it is. And if we don't have all those things, just a weight. Daily weights will tell you a lot. Fontanelles are great. If they're bulgy, there's too much. If it's sunken in, it shouldn't be. There's all different sorts of diarrhea in children. So how do we treat diarrhea? Well, diarrhea, you're still not vomiting. You still can take stuff in by mouth. So you would think, well, if they're having diarrhea, make them NPO. No. If you have diarrhea, you need to give an oral electrolyte solution, and you need to start feeding them so that the stool can get some bulk to it. And, monitor as we're giving fluids to this child, are we having enough urinary output? The parents are sent home. If it's an infant, are we still having those good 6 wet diapers? If it's an older child, how frequently are we urinating? Is it a small or large amount? So diarrhea, feed them. Constipation is another thing that can happen. It is sometimes due to foods we eat, sometimes due to medication, sometimes due to stress. I've seen infants and toddlers hold their stool for 7 to 10 days. Literally, they have not moved their bowels in a week or more. If you take an x-ray, you see the whole x-ray is all this big white stool. And a lot of times it's this child's cry for attention. This is how they get attention. It's the only thing they can control. So if they're having something going on, maybe they moved, maybe, their dog ran away, who knows? They lost their best friend in school. These are stressful to these kids. They can stop their stools from coming. And we would just give them an enema and get them going. And then, of course, watching their stool from there on. We've been talking about constipation on that newborn child. That first day, day and a half, we know already that cystic fibrosis. If we see a child constipated, has not moved their bowels, we're going to be checking them for cystic fibrosis. We've talked about hypothyroidism. We are going to be checking them for thyroid problems. And now we're going to go into Hirschsprung's disease. What is that? Why wouldn't you have a stool with that? And then, of course, any narrowing or non-opening, of course, is going to cause constipation in the GI tract. Constipation, as I said, could be due to what they're eating. Now, formula-fed babies tend to have more chance of constipation than you would see in a breastfed baby. It's just what it is. Breastfed babies tend to have more stools. So if we are having constipation, it might be the bottle fed, the formula fed infant. Maybe we needed to add some juice or something. And this would be arranged with the physician, what would be the best choice. They don't like to go to medicines, do it naturally. So another thing that causes no stool the first day, day and a half after birth is something called Hirschsprung's disease. It's also called megacolon. And if you look at that descending colon, you see how big and outpatched it is. But look underneath where it comes down at the rectum. What happens, this big outpatching area has no nerves. It's called aganglionic, which means there's no nerves. There's no peristalsis, there's no nerves. And then all of the fluids, mucus, whatever, coming down just stretches out this colon, and it keeps stretching and stretching, and it doesn't empty. Sometimes a little bit will squirt out that tiny little rectum, but you'll see it as a little ribbon that comes out. So what do we do if we see this x-ray? Because we feel probably this lump in that abdomen, and we see this megacolon, this Hirschsprung's disease going on. We need to confirm, is it really Hirschsprung's? Because we're going to have to do surgery and take out this portion of the intestines. So we're going to do a rectal biopsy, and it will see, does it have nerves or not? Vomiting, children, they can vomit. They can, just have everything and just vomit out once, or they can just spit out things. There's different reasons for vomiting. But let's say a kid was doing well, and all of a sudden, the brother had a GI problem. Well, of course, now the baby's got the GI problem. So you have a young child vomiting. Well, number one, you're going to check them for signs of dehydration. If they have fontanelle, you're going to check it. You're going to check a heart rate, your vital signs, capillary refill. If they're wet in the mouth, did they just vomit, which would cause the wet? So that's not really as much here. If you have a child who's actively vomiting, you're not going to put anything in their mouth, because all they'll do is vomit more. So you'll start an IV and give a fluid bolus. Now, as we start the IV, we're going to take blood, because we want to know, what are those electrolytes? What is that potassium? Because you don't really know how much has vomiting they've done. What was the quantity? Sometimes this vomiting is just that little spit up. And infants can have reflux. Up till about a year old, you're going to see reflux on infants. And these infants will literally arch. You can see the fluid go up and they arch as you're holding them. And you're like, this child's reflux. Well, it could be due to not burping the child well enough, could be due to overfeeding, could be to positioning the child wrong, should be sitting up after they eat. That could be the reason. Well, if you've done all that, you still continue, then they'll medically manage it with some sort of medicine, Pepcid, all of the things we give to adults, they give to children in children doses, milligrams, micrograms per kilogram. Now, if these children are getting older and they're still losing, remember, they're losing calories every time they're just spitting up this little bit. And you don't want to overfeed them, because they'll just spit up some more. So sometimes they need to go into a surgical intervention. And it is called a Nissen fundal plication. And what they do is literally go into the abdomen, take the top of the stomach and pinch it forward, and it prevents reflux. Okay. And when you're refluxing, what happens? You have a chance of aspiration. So you prevent reflux, you've prevented aspiration. Acute appendicitis. Same things you see in adults, you're going to see in children, same sign and symptoms, right lower quadrant, McBurney point. You'll see that poor little kid walking in, bent over, holding the right groin and limping on the right leg. You got appendix, you can see it because you could see it, and these children are great because if they hurt, you're going to see it. And especially appendix, if they're walking, you can watch, oh, that kid hurts. Now, what happens if all of a sudden it stops hurting? Well, it's usually a ruptured appendix. So either way, appendix is acute or it's ruptured, you go to surgery, you get it removed. Now, if it's already ruptured, that means this area between the small and large intestines, has burst, some of this toxic material into the peritoneum. And it causes a lot of pain and irritation to the entire peritoneal cavity, your intestines. They say, oh, this really hurts. So after surgery, what is our goals? Well, NPO, because we want to rest that intestines. We're going to have IVs and antibiotics, very, very important. We will sometimes put in an NG tube. And what that does, it prevents like gastric juices from going into the intestines, which it's already irritated, so an NG tube. This child, we need to get them up out of bed, not a bed rest, because our goal is to get everything moving again so those intestines start to move. Normal pre-op care in that way, but NPO, antibiotics, and IV fluids and an NG tube. The other thing is if it had already burst into the abdomen, when they closed up that incision, was it good, healthy tissue? You don't know. So you're going to be checking the incision site because this is the one that's going to dehiss on you because you don't know how good that tissue is. So check again your incision. Megacolon diverticulum is basically this little outpatching that has a blood vessel in it. It tears and it leaks blood into your intestines. It doesn't hurt. It's usually the small intestines where this occurs. And the only sign you see is painless rectal bleeding. Sometimes it gets to the point of obstruction, but usually it's just your painless rectal bleeding. And what they do is they go in and they do surgery and they take out this diverticulum and this child as well. IBS, mouth to anus. Remember, GI tract. That is inflammatory bowel. That's what they consider it is. So we have ulcerative colitis, which is subsegments, some Crohn's, and we treat mostly IBS by good nutrition. Usually it's nutrition, making sure they're not eating things that can upset their stomach. Steroids are used a lot here. And if they are maintaining good diet, these children can do well. Peptic ulcer disease, and yes, children can get ulcers. I've seen a 6-year-old with an ulcer, and the mother just said he's just a little worrywart. He worries about everything. So medically, you can treat them, say medicines, Pepcid, any of them. And then sometimes, and I've never seen it, thank goodness, could be a ruptured stomach, which could cause a partial gastrectomy. But if treated and we take care of the underlying reasons, peptic ulcers can do fine. Liver problems, hepatic disorders could be due to many different things. As a nurse, how are we going to take care of this child nutritionally? Because always nutrition is going to be on the forefront of everything we think about. Children with problems with hepatitis should have high in protein and carbohydrates, but low fat. Well, liver, bile, digest fat. It's not going to digest fat. So what happens to fat non-digested? Your belly blows up, abdominal pain, and it's going to hurt. So high protein, high carbohydrates, and that gives them the calories they need, and it also prevents muscle wasting with the protein. So I said mouth to anus. Well, here's the mouth. Cleft lip, cleft palate. Could be one or the other or both at the same time. And it's all of these things. This is a picture out of the book. Could be one side, the other side, both sides. Could have palate or no palate. It could be a little palate or the whole palate. So depends. Now, my little kid with Pierre Robin also had a cleft palate, had an intact lip. His whole top of his mouth, he had no palate in there. So he could suck a bottle. But what about the kid with the lip? How's he going to put that around a breast or a bottle. So feedings are going to be a big problem. So we try to fix these as soon as we can, usually 2 to 3 months of age. Now, children, infants like to touch things that they don't know about. So you see the elbow protectors on there. Those are elbow restraints, which can be used very well. And that little Logan bar, so when he turns over, he can't rub it against something. Palate, usually somewhere 6 to 8 to 12 months, somewhere in the latter part of infancy. The thing with that palate, and my poor little guy, his name was Jackson, his whole palate was gone. So as an infant, I was allowed to feed him because they knew I knew sort of what I was doing. So I was, giving him the bottle, and you could see sometimes it come through the nose. There's no palate to protect it. So this was a very tricky child to feed, but he just had his palate done and he's doing really well with it. The problem with not fixing the palate is speech, because if you don't, they will talk like this, because they cannot pronunciate without the palate. If you look at the bottle to the right, it's called a Haberman's bottle. It's a feeder that the top plastic gets some little bit of milk in it, and you just feed it and slowly you push it. So a child with a clef is going to get that feeling of sucking and swallowing is what they relieve their stress with, right? Some parents do breastfeed. It's so difficult because they're like squeezing their breasts as they feed. It takes a lot of patience to do that. And the big problem is they're not eating enough. Of course, no nutrition. You worry about cognitive delays and growth failure. One of the things that can happen, it's a congenital abnormality during the process, interutero. They don't form an esophagus, or they have connections where they shouldn't be. So esophageal atresia is when the esophagus doesn't go, it doesn't connect to the stomach. There's just a blind pouch there. It just sits there. The other thing that can occur is a tracheal esophageal fistula. So the trachea and the esophagus has a tube that connects them. So you eat, the food goes directly into the trachea, and now you have aspiration pneumonia. So they're both typically the same treatment. That's why these guys are lumped together. What would you see if you had no clue an infant had one of these conditions after birth? Well, you have to swallow mucus, right? Your mouth is wet. It has mucus in it. So they're going to be sputtering, they're going to be choking, gagging, and they're going to be becoming cyanotic because now they're aspirating all this fluid into their lungs, okay? So we need to keep that airway open. And because they're inhaling this stuff, we got to try to prevent pneumonia, which is you're going to be given antibiotics prophylactically before surgery. And these children will end up going and get these things connected. But in the meantime, they are going to be having IV fluids and those IV antibiotics because we don't want, if they aspirate, to get pneumonia. It's like a preventative, prophylactically done. And these kids, even with these defects, they're normal. There's no syndrome. It's just they didn't connect. There's different sort of hernias. We have the umbilical hernia. I just love to push them in and out when they're nice and soft, and it tickles the kids. If it hurts, it's hard. It's a strangulated thing. And this hernia will need a surgical intervention because it's twisted and now the intestines is dying. So as long as it's pushing in and out, it's fine. Once it gets hard, painful, it needs surgery now because of, the incarceration or strangulation. Another sort of hernia that occurs and most serious for a newborn to be born this way is a diaphragmatic hernia, which means there's a hole in the diaphragm. The diaphragm separates the intestines from the lungs. There's a hole. Guess what those intestines do? They go up and they occupy the left chest and they squish the left lung. The left lung never, ever forms because of this pressure there. And the right one's being pushed with all of this intestines. So these children come out, they're really starved for oxygen. And our biggest goal is to just ventilate these children, have them exchange oxygen and carbon dioxide. Many of these children end up on ECMO, which is similar to the heart-lung pump, until we can do surgery, pull those intestines down, you know, and put a mesh and seal it down. But that left lung will never be. Pyloric stenosis is a hypertrophic valve. Now, at the end of the intestines is a pyloric sphincter, and it gets thickened, and stenosis is like narrowing, right? Osis is a narrowing. So it's really narrow and really thick and muscular. And when you have a child suspected pyloric stenosis, these are very young, 3 weeks to 3 months, 2-3 months. Usually like 6-7 weeks is the hot spot that I've seen the most, and I've seen many. These children will eat normally, and they're hungry, and they eat and they eat. And then all of a sudden, they are going to vomit worse than The Exorcist. It'll be across the room, 15 feet away, you're going to get splattered. It is quite forceful vomiting. That's one of the key symptoms. Child comes into the emergency room to the doctor. You're going to ask, so do they vomit just dribbling, or is it going out? And if it's going out, we know that probably this is the pyloric stenosis. Next thing, you're going to feel the middle of the upper abdomen. You can feel this thickened valve. It feels like an olive, the size of an olive. And you're like, okay, for sure. You're going to tell the parents to make this child NPO, nothing to eat or drink now. They'll go over for an ultrasound. They will diagnose it. Surgery will come. Your IV is going to be started, and you're going to send them to the OR. Postoperatively, these children usually eat within 4 to 6 hours after surgery. They start with clear liquids and they work to regular. If it's breast milk, they'll go right to breast milk, but we'll give them in a bottle to measure to start with, and then they can go to breast, and they're home by the next day. Very quick, and nothing reoccurs. Remember, this is a brand new baby. These parents are going to be very emotional. Intussusception is when you have the intestines and a piece sucks right up into the other side. And this is 3 months to 3 years. The youngest one I've ever seen was 5 months. I've not seen down to 3 months, but the book says it is, so it must be. And this, you will see a child come in severe pain, kicking their legs, tense abdomen. So when they're in pain, we send them for ultrasound and we'll see, yes, it is. What do we do? Well, if it's not popping out by itself, we'll send them over to X-ray, and the radiologist under fluoroscopy will insert a rectal tube and pump air into the rectum. And they pump it to the point where it pops off. So hopefully the intestines comes apart and not need surgery. If that doesn't work, the kid will go to surgery, but that's very, very rare. Usually by the time they come in and we get them to ultrasound, the pain is gone. So it's already come out by itself, and they're sent home on a high fiber diet, to come in if we see it again. Malrotation Vulvas is basically a intestines where interutero there was something that wrapped around it. It's rotated wrong, sometimes tied in a knot. You're going to see, and it's the symptoms you're going to see with appendicitis, but it's not going to be the right lower quadrant. Usually it's left upper, and it can, because it can burst, cause the peritonitis, etc., and surgery is required. Anal rectal malformations and imperforated anus. Have you ever seen a baby without an anus? They need a colostomy right away. You have intestinal juices. It has to go somewhere. And then we can have things where you have connections between the intestines and the bladder, or the bladder with the vagina. And you're going to see, I've seen actually stool coming out of a vagina. I've seen the hardest one to pick. If it's a girl, if it's a boy, you can see the urine coming out, you know, the rectum, all different things. So as a nurse, we are the eyes when we see these things. They're not always known at birth. Celiac disease is an intolerance to gluten. And this is the small intestines. And wheat, rye, and barley cannot be eaten because it flattens the cilia. It causes, when you eat gluten, severe, severe abdominal pain. The problem with celiac disease is these children do not absorb fat. And what you see is a stool, because it has no fat in it, it has no color. So it's pale and it is stinky, malodorous, it smells. And because they're not getting all the fat vitamins they need, they're going to be with malnutrition and they're going to need some sort of vitamins. Short bowel syndrome. This happens when we have to take a piece of intestines out, and it decreases the area where the intestines can absorb nutrients. The one story I'll tell you is little Jessica came in, cardiac surgery. We started to feed her post-operatively, and all of a sudden her belly got big, and we started seeing aspirates in the feeds that we were giving her. That's why we measure, you know, if you have a tube in, what are the amounts of fluid formula in there? And abdominal girth. How big is it? Is it getting bigger? So it's not passing. So this child ended up with something called necrotizing enterocolitis. You know, we have periods in our life at birth, a cardiac child like Jessica, where there's periods of hypoxemia, which could be affecting the bowel. And then the bowel gets food in there and is overworked and starts to die. And it causes necrotizing enterocolitis. Little Jessica had 58 centimeters of her small bowel removed. She went home with a G-tube for feeding, small, frequent amounts, and a Broviac central line so we could give her hyperal lipids at night to give her the nutrition she needed because she had such a small area to absorb. And then we know children will eat anything. Most common are vitamins. I've seen rat poison once. That's very dangerous. The vitamins with iron, because too much iron is really dangerous. So when children come in with, you know, eating any of these things, the thing is to get these children to call poison control. Triage is the first thing we do. We get the story, do our vitals, make sure the child's fine, call poison control, and find out the latest and greatest treatment for that day. We know there are areas that have lead paint. Kids teething will chew on windowsills. You know, if it has lead paint in it, they're getting lead. And that's our PowerPoint for today. Any questions? Have I put you to sleep yet? Not yet?
No.
No, not yet.
Okay, who wants to win a Kahoot? Mercedes gonna win today? Tanisha, you're the one.
I probably won't win, but I'll still play.
There you are. You know, trying is what you need to do because that's when you remember. And we should be done about 4:45, I think. All right, let's get going. GIGU. A lot of different things. A multi-select. All of the following are symptoms of dehydration in an infant. What do you see? And I can name a lot more. So we will see very good. Dry, pale skin, weak, loss of elasticity, decreased urine output, sunken fontanelle, elevated heart rate, decreased blood pressure, all of those, very good. And Mercy's up top. What is priority treatment for a child with dehydration due to profuse vomiting? What's the treatment for vomiting? So if you're vomiting, you're of course you're going to name them MPO, but we have to treat dehydration. The treatment is IV fluids, 10 to 20 milliliters per kilogram, bolusing, depending on how dehydrated they are. What is the treatment for an infant with diarrhea lasting for 4 days? So diarrhea, we're gonna feed them. Diarrhea, we feed them. They're not vomiting, they can take it in. Vomiting, if you give it more, they're gonna vomit. So remember this, diarrhea, feed them, give them some fluids, give them some crackers to start with, start a diet on them so you can tighten that stool up. And they usually will give a probiotic with it. What acid-base imbalance may you see with a child that is having profuse diarrhea? So if they're having diarrhea, they're getting rid of a lot of alkalotic material due to the stuff in the common bile duct, the pancreas, the liver, all of those things. So it is metabolic acidosis. I will warn you, the HESI had 4 acid-base questions on it. You're going to see me, I've been throwing these in here. So make sure you know that prior to going sitting for your HESIs. Multi-select. If an infant has not passed the meconium stool in the first 24 to 36 hours, what would you assess for? Very good. I mean, constipation has nothing to do with electrolyte imbalance, but hypothyroidism, cystic fibrosis, Hirschsprung's will all be looked for in case if we didn't know. Deficiency of vitamin D, what is that called? Vitamin D works on joints and muscles. It's a fat-soluble vitamin. And it's called rickets. Scurvy is vitamin C, which is a water-soluble vitamin. We have a unicorn here today. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So now you have both. What are you going to do? IV fluids. Good job. Profuse vomiting. You're going to give nothing in that mouth. Very good. A multi-select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? So remember, that means the appendix and all of the toxins bursted into their abdomen, creating peritonitis. What are our concerns post-op? So IV antibiotics priority, NG tube to keep that stomach empty because those intestines are angry. And we are assessing that surgical site because that was tissue that may not be as good as it should be because of the toxins the appendix put in there. And complete bed rest, absolutely not. We want to get those intestines moving. How do we start the gas moving and passing flatus? Having them out of bed and walking, sitting in the chair. The unicorn is on fire. Passage of urine, usually at night in children who should have voluntary bladder control, is called what? It's called enuresis. Now, epispadias and hypospadias are both with a male. It is a male born, instead of the urethra comes out and it goes out of the tip of the penis, the epispadias, there's a hole on top. It's not here, it's on top, okay? And if it's hypospadias, it's underneath. So hypospadias is a hole here, epispadias is up here. So you're saying, well, what do we do? Well, they take the foreskin, they need to use it for plastic closure of it. Then they put this little stent. It looks sort of like the women's straight catheter, that thin, clear tube. They put it inside the penis and they'll send it home just to leave it there, just to keep the patency of the tube going to the end of the penis. And that's the treatment for it. This again was a Pierre Robin child, had a hypospadias, my little Jackson. I got to see it firsthand, that little stent. What is Hirschsprung's disease? So Hirschsprung's disease is megacolon, that big out patch. There are no nerves there. Absence of the parasympathetic ganglion cells, nerve cells, okay? No peristalsis. There is no feeling in there, and they have to remove it. What types of stool would an infant with Hirschsprung's disease have? So remember, there's this big out patch to the descendant colon, and there's a tiny little port to the rectum. What type of stools do you think they would have? I mean, you have to pack a lot of stuff on top of it. Some don't have any, but some have. Just little tiny little ribbon stools, yes. I try to refer it to as when you put icing in one of those little funnel things and you squirt it and you write the name, that's exactly what Hirschsprung's disease stool would look like. Which is a condition that occurs mainly in children when the intestines telescope into itself. And it is called intussusception, and it could come out by itself, 5-fiber diet, or it might need up to the point of surgery. Gastroesophageal reflux disease, GERD, what's that? And that's when you see the fluid coming up into the esophagus, big risk for aspiration. Now, there are some older children who have GERD, reflux, and what we'll see, those symptoms we'll see in them is because this is coming up, they're going to feel that pain, epigastric pain, abdominal pain, and then they're going to have a cough because it's trying to go into the lungs. It's trying to make an aspiration. So you can see cough, cough, and you're going to complaining of the epigastric pain. And that would be GERD in them. The infants, you're just going to see them cry and see them arch. Inflammatory bowel disease involves what? What did I tell you about the GI tract? Absolutely any part, mouth to anus, bowel, that could be anywhere. Good. What would the nurse be looking for when a patient has Megacolon diverticulum? So remember that's that little skin tab thing and it rips and then blood just pours into the intestines and you don't feel it. It's not painful. You just see the blood. So painless rectal bleeding. Twisting of the bowel, blocking the lumen of the intestines is called. Whether it is, some structure was twisted and bent or not made intrautero during fetal development. And it's called a volvulus. And again, those symptoms you most likely will see to the point where they're like appendix. You'll see pain, and if you let it go too far, they'll rupture. Same treatment. A school-age child goes to the ER due to abdominal pain and vomiting for the last day. What assessment is your priority? What do you need to ask this child, these parents? And it's, what is that pain? Tell me, where is the pain? What makes it better? What makes it worse? All of those things are great questions because you can narrow it down. Is it an intussusception? Is it an appendix? What is it? We can determine. Is it just epigastric pain? What would the nurse expect to see in an infant with biliary atresia? Well, biliary is bile, which is liver. Atresia, A is without. That means there's no opening going into the common bile duct. So there's no bile going into the small intestines, which means there's no fat absorption going on. And you will see no color in those stools, and you will see, because of fat not being digested, abdominal distension. Good. Good job. What structure of the mouth can be impacted by cleft lip and palate? And it's all of it, hard, soft, and the soft is the back, the hard is the front, if you were wondering what the difference was, and of course the lip. What is the most common associated syndrome for cleft palate? I've mentioned Jackson about 4 different times already. I'm going to tell you, you're not going to remember all the syndromes. It's only after you have a child who has one or you see multiple are you going to remember. But this one is called Pierre-Robin sequence. It's a syndrome. And they have a tiny little jaw, and cleft lip, cleft palate is one of the big things. The hypospadias is another one. Cleft lip repair is done when? Remember, the lip cannot go around a bottle or a breast, and the child is hard to suck. So when do you think we would do that repair? And that's 2 to 3 months, basically as soon as we possibly can, to give that child that chance to suck like a normal infant. When does the cleft palate repair typically occur? And that's somewhere between 6 to 8 to 12 months, right around there. So 8 to 12 months was the best choice here. 4 months is way too early. Esophageal atresia. What does that mean? We talked esophageal atresia, and we talked about tracheoesophageal fistulas, both. It's fluid going into the lungs. When you think of these two things, think of aspiration. So esophageal, the stomach and the esophagus, it doesn't attach. So you have the esophagus going nowhere, and you have the stomach there, so eventually you can connect it. Unicorn's fighting hard here. What are the classic signs of esophageal atresia and tracheoesophageal fistula? Think about what they are again. There's no openings, or there's openings that goes to the lungs. Or I said aspiration is the big thing. So it's cyanosis, choking, and coughing. And you'll see them like choking, and the mucus, you'll see it in their mouth bubbling. Neonate suspected tracheoesophageal fistula. Nursing care should include what? What do you do for this child? So we want to have the head up because we have all this mucus and NPO. We are putting no feeds in this child because it goes directly into the lungs. A 5-year-old is complaining of epigastric pain and a persistent cough. What would you suspect? And that is gastroesophageal reflux. Excellent. Good job. You're listening. I like it. Signs and symptoms of hypertrophic pyloric stenosis. So pyloric stenosis is a thickened hypertrophic muscle around the sphincter, and it closes it so you can't connect the stomach to the small intestines. And because it's thickened, you can feel this olive type of thing, and it's right at the upper middle abdomen, maybe slightly to the left, but it's right there. I've felt it before. It's very significant. Signs and symptoms of hypertrophic pyloric stenosis. Well, we have a stenotic valve. That means fluid is not getting into the small intestines. What you're going to see is this child's going to be vomiting across the room, but they're hungry. They are so hungry because they keep losing their food. So you keep feeding them, they keep vomiting. You keep feeding them, they keep vomiting. What does celiac disease affect? Where is it? So the celiac disease affects the small intestines. Remember, celiac disease has to do with nutrition, okay? Celiac disease has a special diet. Where is all nutritional absorption and, all of the things from the body to break these down into workable stuff? It's small intestines, and that's how you should remember that. If you have celiac disease, what should you eliminate from your diet? I had one nurse I worked with who used to go to school for every special event and give his son, who had celiac disease, a special cupcake so he could eat it with, the rest of the kids. I thought that father was an amazing man. Wheat, rye, and barley. Anything breaded, keep away from it. Chicken nuggets, fish sticks, keep away from it. It's a simpler diet. It's eggs, it's dairy, it's cheese, it's fruits and vegetables. You can eat all that. Keep away from bread and breaded stuff and noodles and pasta. Today, we're lucky though. There are so many gluten-free products out. Multi-select. Vitamins that children with celiac disease are prone to lose are. I think if you think of cystic fibrosis, you think of celiac, it's the same thing. And these are your fat soluble vitamins. So which one of these are fat soluble? I already told you vitamin C was water soluble. It's like scurvy, right? It's all the other ones, A, D, and K. What foods would you select for a child with celiac disease? Remember what I just said about celiac disease and the diet. Very good. Anything breaded, fish sticks, macaroni and cheese, both no. French toast, bread, no. Garlic bread, no. So good job. Phimosis, what is that? That's one thing I didn't discuss. So boys that are born have a foreskin. And sometimes you can't pull it back. It's stuck. You just can't pull it back. Not that you pulled it down and it got stuck, that you just can't get it over the head of the penis. And parents are told you need to pull it down once a day and clean it. My grandson had a phimosis. I couldn't pull it down. So because I couldn't, we took him in for a circumcision because it was so tight and we didn't want any problems in the future. What is a hydrocele? Think about what the word stands for. And it's fluid around the testes. Very, very, very good. Usually they complaining of pain. They might even have a period of incontinence and it requires antibiotics to treat it. What is cryptorchidism? Cryptorchidism, when you go to your first pediatrician, in fact, multiple pediatrician visits with a male infant, of course, they check their hips and the back and all that good stuff, but they're going to check the testicles. The testicles, sometimes, especially children not born at 40 weeks or younger, their testicles don't come down all the way. Now, as long as you've got a warm room, so, everything could be down as far as it could, you should be able to feel both testicles. If it's inside too long, it will die. So it is something that needs to be watched very closely. And they usually do it in the first about 6 months of life. They'll take and they'll pull it down, and get them where they should be so the child has both testicles. You suspect an infant has cryptorchidism. How would you examine this infant? So if it's warm, the testicles will come down. Ask any man if it's warm, they come down. If it's cold, whoop, it comes back up. You know, so it'll be harder to examine accurately. Good job. A hypospadias. Remember I discussed hypospadias and epispadias. This is something that we are going to be using the foreskin to do a closure on it a little bit later in the first year. It's the bottom side. It is the ventral side of the penis, and the dorsal side is epispadias on the top. So no dorsal and no ventral. A multi-select. How is a hypospadias corrected? So we take the foreskin and we use it as a closure. This could be a problem in the Jewish faith. Just remember that, because they're brisk in what they like to do with the male, but it needs to be saved to be able to do this plastic closure. Then they put that little stent, which I said looks exactly like a female straight calf catheter. It's tiny. It's an 8 French, and it will go in there, and we just sit it in there. What is bladder exstrophy? There are 2 conditions that can happen on the abdomen when it doesn't close as good as it should. One is the stomach can be born on the outside of the body, and I've seen that multiple times. Or the bladder can be born on the outside of the body. And it is, this midline doesn't close the way it should during, embryonic, but it's exposed. Now, the stomach is connected. Everything else is good. The bladder, in this case, is connected. You're still going to urinate the right way. The biggest concern is infection. And what the surgeon does is every day comes in and tries to push it in a little bit more, keeps it all in sterile wrapping, etc. They keep on their back and slowly it goes in. And when they think they have enough skin, it's stretched enough, they'll go ahead and close it. And these kids do well with it. What are the clinical manifestations of nephrotic syndrome? And remember, this has nothing to do with kidney failure. Nothing. So remember, nephrotic syndrome is all about protein. The kidneys don't know to keep protein, and it eliminates them all. When you have not enough protein in the body, fluid goes interstitially and you get swollen all over. How do we treat it? Corticosteroids. But you will know it by the swelling. You will note it by protein in the urine. These children, low salt. We will fluid restrict. And remember, daily weights, I&O, are the most important things nurses can do. Children with nephrotic syndrome are often given which medications for fluid overload? Look, and remember, nephrotic syndrome is the loss of protein. So hypoalbuminemia, it's going to be super protein in the urine, proteinuria, like 5+, if there was a word for that. But if we give some protein back to this child, and then we pull out some fluids interstitially, because that's what the body wants. Albumin is protein. Then give some Lasix behind it. You're going to have a really good urine output. It's a very complicated thing. In theory, it works beautifully. I've watched it. What is used to treat nephrotic syndrome in children? prednisone, steroids. Yes, it is. Very good. And then maintenance, low salt, decreased fluids, and to monitor their weights. Very good. What is priority nursing care of a child with nephrotic syndrome? What's the most important thing? Monitor daily weights. I'm not going to increase salt intake. I want to decrease salt intake. The kid is swollen, it is edematous. Decrease fluids, decrease salt, monitor daily weights, intakes and outputs. Why is erythropoietin used in chronic kidney failure? What's erythropoietin? And that increases the production of red blood cells. Most chronic kidney failure people, adults, children, don't matter. They have low hemoglobin hematocrits. You know, they don't make enough cells and they die quickly, and you're going to see low levels. So we give some erythropoietin, and it's going to decrease the quantity of blood transfusions this child might need. Multi-select. Children with CKD have renal osteodystrophy. What can this do to the child? Again, you don't know the word. Look at it. Osteo. What does osteo look for? Well, osteo is a bone. Dystrophy means it's not shaped right. It's abnormal, right? And what can this be due to? Well, parathyroid, if you remember from last week, parathyroid produces calcium. If the levels are high, too much calcium is being produced. Then you see the skeletal abnormalities and you see growth retardation. Uric acid, yes, it is kidneys, but it doesn't have anything to do with renal osteodystrophy. A diagnostic finding of acute glomerulonephritis may be. Now, I've asked this in different ways. I've said acute episode of pharyngitis, strep infection, I've said those, but now I've given you a lab value. Which lab value measures strep? And it's an ASO titer. Excellent, good job. In the first class that whoever answered it got them right. Which complication of peritoneal dialysis is most important? So we do not want to hurt that abdomen. That peritoneum is our kidney. There is no other way to get rid of toxic waste. So the most important thing to monitor, to watch out for, is abdominal peritonitis. We don't want an infection. So you see changes in fluid, sediment, whatever, call the doctor. Get this child on antibiotics now. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? I've seen a young boy come into the ER, to the triage. He was playing hide and seek or one of those games, and he ran back into a trailer hitch. And the back of his back was this huge, huge ecchymotic area. When I looked at the lab results, his potassium was 7 something. And I was like, I didn't realize that. But again, kidney, think potassium. A multi-select. What would the nurse anticipate for a child who just had a renal biopsy? Remember I told you it's very similar to cardiac cath. INO, bed rest, we don't want to remove that clot, and watch that dressing to make sure it's not oozing urine out or into the peritoneal cavity. Good. What would you do if the fluid draining from the peritoneal dialysis has changed color and is now cloudy? You're going to suspect an infection and you're calling the doctor, and this child's getting on antibiotics right now. Very good. Better safe than sorry when you're dealing with the only thing they have. Last question. What would the nurse provide to an infant that cannot eat normally? We're talking about esophageal atresia, tracheoesophageal, fistula. Those kids can't eat. What do they need just for their normal growth and development? And that's that non-nutritive sucker. You're putting nothing in this child's mouth. It's going to go directly into the lungs. We don't want to do that. We're going to leave the mouth alone. No, we're just going to let them suck. Let them decrease their stress, satisfy their own thing. Let them suck. Very important. Number 3 is Mercy. Good job, Mercy. Number 2, oh, our unicorn. I like that unicorn. Cute. Number 1, Mary. Good job, Mary. Number 4, Leland and Sam. Good job, Sam. Good job, Leland. What I want you to do is sign your attestations, please, so that we can make sure that you have all of your points of entry this week. And do I have any questions at all? Thank you, guys. Have a good day. Anybody who wants to review an exam, just let me know. Give me a holler, and I absolutely will. So thank you so much, guys. Good night.
Thanks. Bye.